We have a special treat this morning. We have Sara Chrisman talking to us. Sara I've gotten to know Sara over the last few years, and it's been special for me because Sara's an expert on concussion. She's a board certified pediatrician and board certified in adolescent medicine as well. I don't know if you know, it's 3 years to be a pediatrician and another 3 years. You might as well have done a neurosurgical residency. It's maybe 6 or 7 years until you can do both, right? It's 6 years of training. So it's a little bit like neurological surgery. Sara grew up on the East Coast. She went to Penn for undergraduate and then the great Penn for medical school, and then came here and did her training. And she also has an MPH. Great researcher. She's the PI on this NCAA DOD sports concussion research grant and multiple other grants that she has. In her primary interest, well, one of her primary interests in concussion is to kind of look at the long-term outcome of people. This is one of the most, this is probably one of the most challenging things we deal with in mild. I don't think concussion properly should be called mild, but in concussion, the 20% or so that just don't return back to activity in a timely fashion. But anyway, I could go on more about Sara. She's a great clinician, she's a great researcher. She's a wonderful resource for us. We work with her closely, and I thank you for shaking you up in the morning to come all the way over here. That's a big commitment, so thank you, Sara.
Thanks, Rich. Is this working? So thanks for that nice introduction. So as Rich says, I'm not a neurosurgeon. I'm a pediatrician, and I'm not talking to you about a neurosurgical problem. So bear with me. We'll see where this what your interest is in this area. So I'm going to talk to you today about concussion, and specifically about, as Rich said, these kids that have symptoms that last for a longer time. And my only disclosure is that I do have a lot of funding that comes from sporting organizations as well as from the DOD and the CDC. This is just to say that, as Rich describes, I have a master's in public health and an epidemiologist, but I also have a background in neuroscience, and I sort of come at concussion from that perspective. And I also did some work in mental health at NIMH, and so those kind of all meet for me when I think about concussion. So today I'm going to start with a little bit of a background about concussion, just to make sure that we're all on the same page. I know as neurosurgeons, I would imagine you know a lot about brain injury, but just to sort of know that we're talking about the same thing, and then talk about what I mean about persistent concussion symptoms and how we define that. Some of the theories about why concussion symptoms might last longer and not go away, and what are some of the approaches to management of persistent concussion symptoms. So I feel like it's better to show what a concussion is than to describe it. And I would imagine many of you saw this this past Sunday. So this is Brandon Cooks. He's working on my gift skills. But yeah, so that he's hit first in the helmet, sort of the front face mask, then he hits again, hits the ground. This is a common mechanism of concussion, that there's actually a double hit. There's another football concussion. You can see that football is commonly something that we see concussion in. It's not the only sport that concussions occur in. So here's soccer. And, as Rich said, I'm the main PI for the NCAA study here. And we have concussions in all sports. Swimming with the flip turns, there's volleyball, you hit the ground. And you also don't have to be doing sports to get a concussion. So lots of kids doing stupid things. And as you all probably know, also motor vehicle accidents and pedestrian versus car, lots of other etiologies. This is just to show that part of the reason for a concussion is, as you know, the brain moves within the skull, and so that you actually don't have to have a hit to the head to get a concussion. You can have a hit to the body and that impact. And that part of the reason that you get a concussion is also often that there's a whiplash component, that there's often a neck snap component, because then the brain is moving more within the skull. And when I first started studying concussion, I sort of had this thought that, oh, if you get hit on the left side, or you get hit in the occipital lobe, you're going to have different symptoms. And actually, most concussions have the sort of core symptoms that are similar, and that's because it's actually a midline injury. It's actually a stretch injury to the axons. It's a white matter injury, or that's our best theory these days. Christine's doing some studies. Hopefully, we'll have more information about that. But that you can't see it on imaging, but it does seem to be that it's actually the white matter, which is where the damage is occurring. And as a result, you tend to have symptoms that are from the midline. This is to show you, this is why I think when you talk about concussion in words, it's a nightmare, because this is actually from the Berlin document, the consensus. There's been these concussion consensus conferences that are the people who take care of professional athletes get together and talk about how we should manage concussion, but you end up with really just a lot of words that don't mean anything more other than you got hit in the head and you don't feel right, and we can't see anything on imaging, and you weren't drinking or doing something else that would explain it. And so really this is where we are with concussion, is that we have symptoms, and that's how we're defining it. There's no blood test that will say that you definitively had a concussion, although the DoD has certainly spent a lot of money trying to find like a blood test. We've tried force monitors, we've tried even with neuropsych testing, there's really nothing that is actually more sensitive or specific than symptoms, unfortunately. And they sort of can be generally divided into physical, cognitive, emotional. Most people with concussion are going to have headache, and part of that is because if you have pain, it makes you more likely to go and talk to someone about it. But the sort of core feature of concussion is that feeling of like my brain is not working well, which can be described in different ways. So some people will say, I'm having trouble concentrating, I feel like I'm in a fog, and David Koppel, I think, always had that nice thing of talking about when your computer is spooling. And so it's that feeling of it's just not, it's not working right, I'm just not connecting. And that you'll often see with an athlete where they'll be like slow to respond, which makes sense when you think about if the axon transmission is not working well, that you might have that sensation. There are also emotional symptoms of concussion, and there's some debate about this, that whether that is actually a primary part of the injury or whether that's secondary or whether that's revealing an underlying issue. Clearly the amygdala and the hippocampus are midline structures, and there could actually be some primary injury to them. But also having an injury itself, specifically concussion, which right now is in the news and has a lot of fear associated with it, has also brought up a lot of emotions for people. So why do I study concussion? Well, part of the reason is as a pediatrician and as an adolescent medicine provider, I take care of kids with lots of different issues. I take care of kids with obesity, and I think physical activity is really essential and important, and trying to find ways to make sure that we can have kids be safe when they play sports. We know that, well, this is a recent study with Fred Rivar and Marcin Bryan looking at a bunch of different data sets, and the estimates are that about 1.8 million youth in the US sustain a concussion each year. And so this is something that we really need to focus on and understand better and know what to do about. Most of those kids get better. And so even with all of this stuff in the news, we don't have any evidence that one concussion is going to be a problem later on. And most of them resolve fairly quickly. 1 to 2 weeks, there's some, the consensus statement actually pushes this a little bit longer. There's sort of a question of like, how long are you symptomatic? Is it 2 to 4 weeks? But in any case, most people feel comfortable that saying if you have symptoms longer than a month, that's longer than we would expect. And we do have a number of kids that have persistent symptoms. And so how do you define persistence is a little bit of a debate. So there is actually a diagnosis of prolonged concussion syndrome, or PCS, which is symptoms greater than 3 months. And that was like kind of tailored more towards like the chronic pain kind of diagnosis. But most people begin to be concerned earlier than that. And so we've used this 1 month because we want to make sure that we're actually intervening before it becomes more of a chronic issue. When you look at athletic trainer data, so athletic trainers who are on the sideline of a sports team are going to be there and capturing most of the concussions, and they're also following those kids closely. The kids are also wanting to get back to play, so they have a smaller proportion of kids that have symptoms greater than a month. This is probably biased towards the low end because some of those kids are probably like, well, I'm not really better, but I'm not going to tell anybody, and they're going back sooner. And so in those populations, it's about 5% of kids that will have symptoms longer than a month. When you look at ER data, it's more like 20 or 30%. ER, clearly is a biased sample where you're getting kids or that are more severe because someone has had enough concern to bring them to the ER, whether they had a prolonged loss of consciousness, whether there's more distress around that. There may be different factors that go into that. And tertiary care clinics also have a higher rate. And of course, to get into a tertiary care clinic, you have to have had symptoms that last longer enough to get through the referral process and all of that. But this is part of the reason that it's been a focus, is that when you look at our tertiary care clinics, sports medicine and rehab medicine, we see a large proportion of these kids that have persistent symptoms, and trying to understand how to manage them, what to do with them, has become a kind of an increasing problem. These kids also tend to bounce from clinic to clinic and then sort of see multiple providers within the system, which can be a drain on the system. We worry about their outcomes. So with an adult, you're worried about them going back to work. As a pediatrician, I'm very worried about kids getting back to school. Because when you start missing school, you miss a week of school, you get behind, it's then harder to catch up. And we see these kids that have missed weeks of school, months of school, and then they actually just can't even get back. They go to online school, they may even end up not being able to continue with school. And also along with that, social withdrawal, depression, all of these other associated factors. And so for that reason, that's why we want to make sure that we're intervening early on so that we can prevent this sort of cycle. So why do we think that kids would have symptoms that would not go away? Well, initially, there was this thought that it's a more severe injury. So concussion is an invisible injury in that we can't see it on our current clinical imaging. And so it may be that there's a range of how severe that injury is. This may be a component, but it clearly doesn't seem to explain all of what's going on. There's also been this thought that if you had underlying neurologic issues, whether it was a previous brain injury or whether you have a learning disability, you have some congenital reasons that you had less brain reserve, and having the secondary impact of a concussion, it may disrupt your function, and so that you may see that subtle problem for longer. So as I described initially, we know that concussion often has a neck component, which means it can be a whiplash injury plus concussion. And if you have someone who has a whiplash injury that hasn't been adequately treated, that can actually, when you have neck strain, that can be perceived as headache. And so someone might have chronic headache, which is actually from their neck, and that then they could have persistent symptoms. There's been increasingly this interest in vestibular issues. And so this is sort of for multiple reasons. When you have a traumatic injury, you can disrupt the otolith, so you can have a primary vestibular issue. There's also, clearly cerebellum, other vestibular areas that are midline. There's some debate about how frequent this is and how much of a concern this is. It's sort of depending on how much of a vestibular specialist you are, I would say, but that is on the horizon as well. This maybe about 5 or 10 years ago, people started to have this concern about cerebral autoregulation, or this idea that when you have a brain injury, the brain becomes less adept at controlling the interplay between systemic hypertension and the pressure in the intracerebral space. And so that you can actually, when you go to exercise, the blood pressure is transmitted into the brain and you get a headache. And so people have said this may be a part of the reason that you have persistent symptoms, is that this is not working correctly. And so you are feeling bad when you exercise. And then, as I described, this mental health piece has been kind of interwoven here. And there's been a lot of work in this area trying to understand, is this underlying mental health that is then coming out because of a stressor of an injury? Is this a primary issue from the injury? Are there other pieces to this, and how do we understand this? And so, of course, these theories about etiology have fed how we've thought about treating concussion when these kids have persistent symptoms. So historically, the treatment was rest. And there's a great article, Noah Silverberg, where he says, rest is the treatment we use when we don't know any better. Rest is what we used to do for back pain, and then sort of realize that there's a certain amount of rest is good, but that at some point you have to get people moving, you have to get people back to life. And so rest is clearly a part of concussion treatment in the acute time period. Most people agree that there needs to be some amount of rest, but there was a point when actually they were saying, you can't go back to play until you're completely asymptomatic. And this really came from these group of clinicians that take care of professional athletes feeling like they had to hold people back, because otherwise someone's gonna, I've got to go play in the Super Bowl. For example, Gronkowski, who got cleared on Friday to play in the Super Bowl this weekend, so that those athletes are always pushing because it's really their career. But then this then got translated kind of down to kids, where people were doing cocoon therapy and saying, okay, so you need to not only rest, but you can't do anything. You can't be on your iPad, you can't be on your phone, you can't talk to your friends, and you need to sit in a dark room, which is really a recipe for disaster for a 15-year-old kid. And so this is shifting. And so the recent consensus statement from Berlin has now said a recommendation of 24 to 48 hours of rest, and then relative activity, starting to begin some movement. And this is one of the studies that really sort of pushed this. There was already this sort of clinical feeling that too much rest was not beneficial. Danny Thomas looked at this it's actually not a very big study, but he was comparing 2 days of rest to 4 days of rest for people who presented to the emergency room. And he found that there was no difference, and actually that those with strict rest, there was a trend towards maybe they were doing a little bit worse. And this started to push people to say, what are we doing? This sounds like maybe it would be helpful, but it's not necessarily helpful. So from that, then there's of course other modalities people are going to think about. So if you have someone with persistent headache, clearly pharmacotherapy is going to come into play. And there, certainly things like Tylenol, ibuprofen, but those are not really long-term solutions. There's not a lot of data in this area. I think there are some studies. There's some studies here using some of the triptans. There's some people that have used amitriptyline, some of the more chronic pain medications. There's also some studies around sleep, and so some people using melatonin. There's a big study up in Canada. So there will be more on the horizon in this area, but I would say there's not a clear medicine right now that is used in this population. It's more about symptomatic treatment. As I said, because there is this component of whiplash, certainly if you have a patient who has neck pain or seems to have C-spine strain, then having physical therapy or rehabilitative approach to the neck might be an important part of therapy. And this sort of comes back to that a lot of people have now started to say these kids with persistent concussive symptoms, they're not all the same. And we need to think about how do we divide them up and what are the issues so that we can really better treat each of those patients. And the same thing for vestibular therapy. So certainly if someone has a primary vestibular issue, they're going to have different symptoms. They're going to be presenting with dizziness, with vertigo, and maybe with balance issues. And some of those patients benefit from vestibular therapy. Again, there's this question of how frequent this really is occurring. So for those patients who had this, or there's this theory about cerebral autoregulation and this question of that the autonomic nervous system is not appropriately balancing the systemic hypertension with the brain. There's this intervention called submaximal aerobic exercise. People have called this different things, threshold exercise, rehabilitative exercise. And it's this idea of taking someone and having them exercise just below the point that makes their symptoms worse. And then asking them to do that on a regular basis, slowly increasing the intensity, the idea that you're training the autonomic nervous system to get back to normal. And there's a couple of different people that have worked in this space. This started with Isabelle Gagnon, who's up in Canada. She's a rehabilitation physician, and she had this approach to, here are these kids with concussion, they're not able to do this in the same way that we would think about someone with chest pain. If we want to get them back to activity, we start them running until they don't have, if they have chest pain, they stop. And it's the same, she took the same approach to concussion. She actually has a multidisciplinary approach. So she also included some sports skills. She also does some relaxation. It's a little bit of a program that she does. She has not done controlled studies. These are mostly just case series. John Letty is in Buffalo, and he has sort of a slightly different approach. So he started with adults, and he brought people into the lab and had them do a treadmill test. It's sort of like the Bruce protocol. It's called the Balke treadmill test. It's a little bit less intense to do, but you get on a treadmill and you walk 3.3 meters per second, and then they increase the grade of the treadmill every few minutes. And when you have a point where your symptoms are getting worse, then they stop it and they say, what's your heart rate right now? And say, that's your threshold. And then send you home and ask you to do exercise below that threshold and slowly increasing that each week with the idea that they'll kind of get you back to function. And this is his first study was a tiny study. It's interesting, like there still hasn't been really a big study looking at this, but in the meantime, a lot of the clinical sort of care has shifted in this direction. Brad Kurowski with Sherry Wade did a study a couple years ago as similar, but applying this to kids and using an exercise bike. This is a little bit more rigorous, where they actually were comparing to a stretching control. They recruited them from the emergency room. Excuse me. But they still haven't done the full study of this either, and so this is still an area on the horizon. And then the last area that I would say people have started to do intervention is with mental health intervention, so cognitive behavioral therapy, and really the main study that has been done in this area is from people from our institution. So Fred Rivara is one of my primary mentors. Carrie McCarty and Doug Zatzik is actually a psychiatrist who works at Harborview primarily. And Doug has used STEP collaborative care as an intervention for PTSD, for patients that come to Harborview ER, and so he wanted to sort of translate that into the concussion world and say this might be a way to help these kids get better. And so the idea of STEP collaborative care is that you're starting with CBT, cognitive behavioral therapy. If you have kids that have really severe issues, you might also layer in medication, so psychotherapy plus medication. But then you also are working closely with a primary care doctor, working closely, making sure that these patients are getting to their appointments, which is sort of the collaborative care model. And this was a pilot with just 50 subjects. They then from this were able to get an R1, and so are in the midst of the R1 with more of like a sample of 200. And so we'll see what comes from that. But they did find benefit from this approach compared to a waitlist control. And they also noticed that depression was decreasing. And I think one of the interesting things too, their experience has been they have a lot of patients with significant mental health, and they've had to have suicide protocols. They've had to really like be alert to these patients. And these are not patients that are being seen in a mental health clinic. These are patients that are being seen for concussion. So I have worn a lot of different hats in my career. So as I said, I'm a pediatrician, I'm an adolescent medicine doc. I also worked in chronic pain for the past 3 years. I just sort of transitioned out recently, but I was the main doctor for what's called the Pain Rehabilitation Program at the Children's, which is a program that works with kids that have had chronic pain and are very dysfunctional. The program is focused around physical activity. Kids come in and they do 40 hours of physical activity a week, and then have some psychotherapy support. And I would see them every day, sort of to cheerlead them on, like, you can do this. And so what I started to be really cognizant of the fact that these kids with chronic pain were very similar to the concussion patients. And we actually had 2 kids with concussion with persistent symptoms that did that program. And that made me think that some of the concepts that we think of with pain may apply to concussion. And so fear avoidance comes out of the pain literature of Lane and Linton, and has been used to try to understand how someone goes from acute pain to chronic pain, how that occurs. So pain is a little bit different of a sensation. You have an injury and you have nerve damage that causes pain, but then you have your experience of pain, which is also affected by your thoughts and your understanding of what that pain means. And so if you have pain catastrophizing, where you're like, oh my God, this pain means I'm going to die, it increases your fear, increases your perception of that pain, and the pain experience actually changes. And that people can then get into this cycle where they're so fearful that they start avoiding activities, they become disabled, then the pain is actually worse, and they get into this cycle of dysfunction. And the way to get out of that is actually to confront the fear and to do those activities despite being afraid of them and despite pain, which was what the program was really built around. And we had tremendous success. It's still an impressive program. It's a lot of work for each individual patient, but they do very well. Oh, sorry. And so my thought was that this could pertain very well to concussion, and that we could think about sort of the same model, but with concussion. So you have a concussion, you experience these concussive symptoms, particularly in this world of sort of fear around concussion. People are being told, if I am running and I feel a headache, then that may mean something really bad. They're being told that if you do any exercise that's dangerous, you could hurt your brain. And then people start to have this perception of, oh, my brain is injured because I'm getting a headache, and if I do anything, something bad is going to happen. And this catastrophizing then leads to avoidance. They become dysfunctional, and you get into this cycle. And with kids, parents also have a role. So parents who are very fearful of what their kids' symptoms mean, they provide sort of the context of how that kid is responding and what that kid thinks those mean, and so that creates that dysfunction. The way to get out of that is through something like a subthreshold exercise program. And so that's what I was really saying. I think these exercise programs may not be working in the way that you think they are. And so the theory had been that they were acting in this physiologic way, that they're changing the autonomic nervous system. And I thought that people that are going through these are getting better much more quickly than we would expect from physiologic change. And there probably is also a component of mental health, and you're actually exposing them to a feared activity, and then their anxiety is decreasing, and so they're recovering. And so this is my conceptual model for this study, the subthreshold exercise program, that it's both acting physiologically and through mental health. So you're increasing moderate to vigorous physical activity, but you're decreasing fear avoidance, and both of those go towards decreasing concussive symptoms, and both of them go towards increasing overall health-related quality of life. So when I first started looking at this a few years ago, Children's actually has one of these subthreshold exercise programs that they modeled after John Luddy's program. It's called the SSTEP. And so I just did a chart review of some of those patients. This was actually 100 patients. This is chart review data, so it is what it is. We had standardized concussion symptom inventories that had been entered into the computer. The SCAT2 back in those days, we're now up to the SCAT5, but that was a SCAT2. And you can see that people got better. It's clinical data, there's no control, it's an injury, so everyone should be getting better. But it was at least a start to say we should do some more work in this area. So from that, I decided to do a pilot study of a subthreshold exercise program. I basically recreated the children's program in a research world. So I brought in my own physical therapist, designed a 6-week intervention. I decided to have patients come in at 2 time points, at baseline and at 6 weeks, and then we had a research assistant call them weekly in between. So when they came in, they were randomized to either a subthreshold exercise program plus stretching or stretching alone. And part of this, I really wanted to have an active control because I was worried that otherwise people wouldn't refer their patients to the study, because really as things have shifted, this idea of like having someone rest or not do anything wasn't going to be acceptable to most clinicians. Primary outcome was concussive symptoms, but I also was interested in this idea of fear avoidance and trying to look at that eventually as a mediator. Clearly in a pilot wouldn't have the power to do that. This is just to show you, so we actually had people come in and do this Balke treadmill test. This is not one of our subjects, it's just someone doing the Balke treadmill test, but it's just to show you that they come in and they go on the treadmill, and we use this methods to try to understand what was their threshold. So as we're increasing the intensity of the treadmill, they would be rating their symptoms, and if they said, oh, my symptoms are worse, then we would stop. We say, what's your heart rate right now? And then that would be their threshold, and then we would send them home with an exercise program that was below that threshold. And we gave kids heart rate monitors that they could then, that had their threshold into it so that they knew what their target was. And we also measured their physical activity actually objectively with accelerometry, and had the benefit of working with a lot of physical activity researchers, and so we could measure where they were at baseline and step them up from that. This is just to show you that even it's a small trial, we had 30 patients. You have to go through a lot of patients to get down to that. Part of it is with injury, people get better, which is good. And so we screened like over 200 patients, and 100 of them already didn't have enough symptoms to qualify. But as you go down, when we got to the ones that were eligible and that were randomized, most of them did stay in the trial. And actually, all of our kids really liked being in the study. They got paid a little bit. They like that, but they all genuinely seem to like it in general. This is just to show you our sample. As I said, a pretty small sample. We had a randomized stratified randomization, but we also were biased towards the intervention because we were interested in understanding the sort of feasibility, accessibility of the intervention. So that's why we had 11 in control and 19 in the intervention, about equal male and female. The average age was about 15 to 16. And we allowed kids to be 2 weeks to 6 months after their injury for the entry into the study, and the average was about 2 months. And we have no sport that predominated. I mean, you can see the most common category is other. We had swimming, we had ultimate frisbee, we had dancing, basketball. So they really were all comers. Most of these kids came from sports medicine at Children's or rehab medicine. We specifically looked at sports concussion rather than also including some of the motor vehicle accidents. And part of that is that it's more complicated. So when you have kids that have been in a motor vehicle accident, they're usually not normal in the sense that maybe their parents were drinking, and so they may have the psychosocial differences because they have sort of higher risk factors. And so it's not to say that the injury itself is different, but that it has more complexity in terms of making sure that you control for some socioeconomic factors. And so this one we sort of focused on sports-related concussion. About 50% of these kids had a previous concussion, or another way to think about it is that a lot of these kids, this was their second or third concussion, which has been described before. So this is just as to show you sort of the way the study was laid out. So baseline, 6 weeks of intervention where they were doing symptoms weekly and talking with the research assistant, and then 6 weeks, 3 months, and 6 months. We actually did pretty well in terms of people completing measures. We had, you know, it's a small study. We had someone whose mom got cervical cancer, and so they, you know, there's definitely, we had some people who sort of drop off in the study, but we did fairly well. Interestingly, there were some changes in physical activity, but it was not different by intervention arm. One of the things, you know, I think as you go into the study, even a stretching control was enough to sort of get people moving a little bit more. But we had a median of 14 minutes per day of moderate to vigorous physical activity at baseline. And the range was 1 minute to 80 minutes. Moderate to vigorous physical activity is like on your Fitbit. When you're in that sort of range, it's fast walking, it's not very much, and these are, any amount is all clumped together. So if you only have 1 minute, you're really doing nothing. So that was very low, but it was good to see that at least both groups went up. And it's interesting, I think it also goes along with some of my hypotheses that physical activity was not changing profoundly, but that kids were getting better. So this is very pilot data, and I should have said I'm in the midst of this analysis, so I'm sort of presenting this before it's fully complete. I'm working with my analyst that was actually who was calling as I was presenting. But you can see that we are seeing a difference between the control and the treatment, which was very helpful to see because as I said, this is a pretty active control. And so it was interesting. And my theory is that this may be because it's an even more feared activity to ask them to do a physical activity that is aerobic. So I'm not sure that it actually is that they're doing a lot more physical activity, but that we are really exposing them to something more scary. So the one on the left shows you the whole study. As I said, it goes out to 6 months. The one on the right just sort of zeroes in on the time during the intervention just to show you the variation, because clearly there also are kids that don't get better. There are some kids that dramatically get better. And we're in the midst of applying for more funding to look at this in a larger sample. And one of the goals is to try to understand what that variability means and to try to know who are those kids who are getting better, who are not getting better, but what are the ways that we can think about parsing that out so that we can help all kids. And this is just to show the fear avoidance that I talked about did drop in both samples as well. When you look at this, these slopes look different. This is a very small sample, so I don't know that those will actually be different. But this is hopeful in terms of understanding that there is this component. And I think one of the other things that's interesting is you see the large range, so that some of these people are expressing a lot of pain, catastrophizing, a lot of fear about what the symptoms mean, and other patients this is not an issue. And that may also reflect that there is a lot of heterogeneity in this population. So that's really all I have. I can answer more questions. This is some of the people that I work with. So Fred Rivar is my primary mentor. Jane Mendoza is a physical activity researcher who I work with at Children's. Stan Herring clearly has been a mentor in a lot of this. He was actually one of the big pushes to have this rehabilitative program at Children's. Monique Burton's one of the sports medicine physicians who's also been involved in this. Ellie Summers is the physical therapist who partnered with me to do a lot of these assessments. We actually had all the patients assessed by physical therapists. And then I have a wonderful support staff, Lauren and Albert with their research assistants who did most of this health coaching and walked the people through. And then we have statisticians, and those are my kids. So part of my motivation to do this work is, both my kids play soccer. Couldn't find a picture of my son playing soccer, but he also does stupid things like climbing on driftwood on the beach, and I'm sure someday they will have a head injury. So hopefully I can figure out how better treatment.